All right, hello everybody, welcome back. We are going to cover chapters 25 and 26 on this PowerPoint, and then we will go over again, as we have done in the past, the procedures together in class. There will be a bit of an element of self-study for the instrumentation for these chapters, just in the essence of time, so that you have a forewarning of that when we get going here. All right, so we're going to start with chapter 25, which is the genital urinary system. Just a short introduction here. The genital urinary specialty, or GU, is going to cover procedures of the urethra, bladder, ureters, kidneys, and the male reproductive system. Excuse me. There are three common approaches used in GU surgery. Transurethral is performed through a flexible or rigid fiber optic endoscope inserted through the urethra, and it allows direct access to the lower urinary tract. Open is performed through an incision in the abdomen or flank, and then minimally invasive and robotic as well. These are the closed procedures using percutaneous endoscopes. And we're going to start again with a little bit of a review of the surgical anatomy. The retroperitoneal cavity is where we're going to start. This is posterior to the peritoneal space. It's embedded and protected in dense muscle, fascia, and fatty tissue. It's covered on the anterior side by the retroperitoneum, and access is gained through the abdominal peritoneum or the flank. And again, these diagrams are from your textbook, so you can reference those. We're going to start with the kidney. These are the primary organs for blood filtration. They are located in the retroperitoneal cavity, usually at the T12 level. That is the thoracic vertebrae 12, with the right kidney sitting just a bit lower than the left. The kidneys do have two main tissue layers. The cortex is the outer layer. It is covered with Gerota's capsule and contains portions of the microscopic tubules that filter the blood. The medulla is the inner layer. It's composed of 8 to 12 large collecting areas called the renal pyramids. The notched area on the medial side of each kidney is called the hilum, and that is where our ureter, renal artery, and vein emerge from. And from the ureter opens up, from here, the ureter opens into the renal pelvis and branches into the renal calyces. And we can see that all here in this diagram. Here we see our hilum, our renal pelvis, and then our renal calyces breaking out here with the cortex, the medulla, and the medullary pyramid is right here. Okay. Each kidney contains approximately 1 million filtering units that are called nephrons. Each nephron is going to communicate with the vascular system through a capillary structure called the glomerulus. Glomerulus is composed of microscopic tubules that communicate with the capillaries to filter the blood. Each capillary network of each nephron is contained within Bowman's capsule. The juxtaglomerular cells in Bowman's capsule release renin, which is necessary for the regulation of blood pressure. And the blood flows into the capillary network through the efferent arteriole. As blood circulates through the capillaries, fluid is going to move selectively into Bowman's capsule. Proteins and cells are going to remain in the blood, but other substances are going to cross the arterial membrane and move into the capsule. The filtrate then is going to move into the nephron tubules. We're going to talk just a bit here about kidney dialysis. The kidneys remove waste products from the blood, as we just said. Kidney dialysis is a procedure that performs this function in patients that have lost that kidney function. It's performed regularly or as an emergent procedure to remove ingested toxins from the blood that could lead to kidney failure. And there are two types of kidney dialysis. All right, hemodialysis is going to include the blood being shunted into a heparinized hemodialysis machine. Blood's filtered and returned to the body. It's going to leave the body through an artery and it's returned through a vein. The process usually takes 3 hours and it's done 3 to 4 times a week. So these patients are very involved in this. Okay, access to the vascular system is achieved surgically with the creation of an AV shunt. The radial vein and artery are anastomosed together, or an artificial graft is implanted to join the two. These patients are extremely protective of those AV sites, and they take extreme precautions to prevent injury to that site, as that is where their dialysis is going to take place, and it is vital to them. Okay, then we have peritoneal dialysis. This is where a celastic tube is placed into the suprapubic peritoneal space, so right above the pubis there. Dialysis solution is instilled into the catheter, and that solution then remains in the cavity and slowly extracts the waste products using the peritoneum as an osmotic filter. The total dwell time is about 4 to 6 hours, and this process can be performed by the patient. We will usually instill that suprapubic catheter surgically, and then they can do these treatments on their own. Okay, the adrenal glands. These lie on the medial side of the upper kidney. There are 2 layers, the outer cortex again and an inner medulla. The adrenal glands secrete glucocorticoids, mineralocorticoids, and the adrenal sex hormones. Blood supply for these comes from the aorta and branches of the renal and inferior phrenic arteries. And these are also important for the production of epinephrine and norepinephrine, which, if you remember, have everything to do with our fight or flight syndrome. Right, the ureters are approximately 12 inches long in adults and about 5 millimeters in diameter. They also have 3 layers. That is an outer fibrous, middle muscular layer, and an inner mucosal layer. And each ureter then is going to enter the bladder at the ureterovesical junction, or the UVJ. Right, the bladder lies behind the symphysis pubis in the pelvic cavity. The bladder wall is composed of 4 main tissue layers: the outer serosa, the muscle layer, a submucosa, and an inner mucosa. The distal portion of the bladder is referred to as the trigone. This is a triangular structure containing both superficial and deep muscle layers. The superficial layer extends into the bladder neck in females and into the proximal portion of the urethra in males. 3 corners that correspond with the ureteral openings, and 1 with the urethral opening. And you can see that here is our trigone at the lower end of the bladder. So here are our 2 ureteral openings, and then our urethral opening. And as you can see, with the presence of a prostate gland here, this is in a male bladder. All right, the urethra enables excretion of urine from the body. In females, it exits the bladder at the trigone, and the meatus is located on the midline of the labia right near the clitoris. In males, it's going to exit the bladder and continue to the end of the penis. It begins at the bladder neck and it passes through the prostate. All right, just a review here of the reproductive structures of the male now. We're going to start with the scrotum and testicles. The scrotum is a layered tissue sac that encases the testicles. Skin contains numerous rugae or folds, and it is continuous with the perineum. The inner layer is composed of fascia and the dartos muscle, which retracts and relaxes in varying temperatures to protect the spermatozoa. The testicles are enclosed in a fibrous membrane called the tunica vaginalis. A septum separates the 2 testicles, and it's composed of tightly coiled tubules called the seminiferous tubules. Those are their main function there. The seminiferous tubules are to produce testosterone. We also have the epididymis, which is a convoluted duct that secretes seminal fluid, which we know is the liquid substance that gives sperm its mobility. The vas deferens join the epididymis with the ejaculatory duct. It's contained within the spermatic cord and can become trapped in the presence of an inguinal hernia. Okay, the seminal vesicles sit close to the ejaculatory duct, at the proximal end, and they are responsible for about 60% of semen secretion. The prostate gland surrounds the urethra and secretes alkaline fluid that contributes to seminal fluid as well. And then we have the bulbal urethral glands, which are also known as Cowper glands, and those lie just below the prostate on either side of that urethra. Right, the penis is a suspended fibrous sheath at the pubic arch by fascia. The corpora cavernosa is two dorsal columns that are composed of spongy vascular tissue that is necessary for functional erections. It is separated by a septum and bound together by a fibrous sheath. The corpus spongiosum then encloses the urethra. And here from your textbook are some diagrams. Here, this one over here is illustrating the tubules here, the urethra. We can see it joins with the vas deferens and the epididymis. And here is our ejaculatory duct. And over here we can see the seminal vesicles. Here is our ejaculatory duct and our prostate around our uterus. The bulbal urethral glands lie just below that. Our epididymis, a testes, the scrotum, and our vas deferens and urinary bladder are over here. All right, moving into some diagnostic procedures. Tests in genitourinary disease focus mainly on the presence or absence of substances that are found in the blood and urine. Imaging tests are done to outline the structures, observe function, and detect tumors. All right, urinalysis is performed to detect normal and abnormal substances in the urine. The presence of protein in the urine is an important diagnostic sign. Albumin is the primary protein component of blood, and very little is allowed to cross that capillary system into the filtrate when going through the kidneys. So specific tests for albumin in the urine are run when kidney disease is suspected. We also can measure our specific gravity with a urinalysis. That's the ratio of density of urine to water. And it's also an important indicator of solute concentration in the urine. It's going to determine that kidney's ability to maintain a fluid balance. All right, certain blood tests can be run. One would be for creatinine. Excuse me, this is a normal waste product of the metabolism in muscles, and it's measured as an indicator of kidney function. We can measure our GFR, which is our glomerular filtration rate. This is going to measure the rate of creatinine clearance from the blood. Blood creatinine begins to rise when the GFR is at about 50% of normal, so that's what we're looking for there. And then we have the blood urea nitrogen test, or BUN. This assesses the elimination of urea from the liver, and it may indicate renal failure. Okay. Again, these are things that are going to be done pre-operatively, but you may hear these terms in the OR, so it's a good idea to at least have a bit of an idea of what they're talking about when you hear these come up. Okay, some imaging studies that we can do. CT is preferred for imaging tumors of the kidneys. Fluoroscopy is done, and that, as we know, is real-time radiography. IV urography is when a contrast medium is injected intravenously to obtain radiographs of the renal pelvis and those calyces. It can also measure the rate of emptying and the sizes of the ureters. Okay, and then we have the KUB. You will hear this a lot intraoperative. Our surgeons will ask if they have the KUB available or if we can get one. And that's going to outline the structures of the urinary system, including any calculi. Calculi refers to bladder or kidney stones. The CT is now the preferred method to do this. However, we will every once in a while do an intra-op KUB. Okay, we also have an MCU, which is a micturating cystourethrogram. This provides images of the bladder while it is emptying. An MRI is an extremely detailed image. It's often used for tumors. We have the retrograde uretropylography. This is made using a catheter that's inserted into the ureter, and that's often done intraoperatively. And finally, we have the ultrasound, which is our first line imaging technique that's used in genital urinary quite often. All right, I want to take just a minute here to talk about lithotripsy. This is a procedure in which stones in the urinary tract are crushed for removal. Calculi, again, as we said, those are kidney stones, are formed by the precipitation of specific salts from kidney filtrate that have become supersaturated. Okay, there are 4 types of stones. Calcium oxalate or calcium phosphate are derived from the different foods that we use in our diet. Uric acid stones form when our urine is overacidic. Struvite are usually related to certain urinary infections, and the cystine stones are derived from a genetic disorder. So lithotripsy can be done. These stones can be removed extracorporally or intracorporally, meaning from the inside or the outside of the body. An extracorporeal shock wave lithotripsy, or an ESWL, you'll hear it called ESWAL, that delivers shock waves that are delivered to the stones under fluoroscopy from the outside of the body. It is extracorporeal. It's used on stones that are less than 2 centimeters. It is less effective on cystine and calcium oxalate stones. Okay, and that is what we are seeing here in this image. So you can see our patient is usually awake or lightly sedated. We are going to keep them covered and comfortable. That is the main role of a surgical technologist in these cases, unless they are going to sleep and having a cystoscopy done as well. We are usually just there for moral and emotional support for the patient and to help the circulator with whatever they may need. As you can see, it's done on a specific table that is usually brought in by the lithotripsy technician. So this here is our C-arm that is going to provide that fluoroscopy live time. And then our shock waves are delivered through the table right through here. And it just makes kind of a loud ticking sound, and it is delivering those shock waves to break up that stone. Okay, we can also do them, as I said, intracorporally. This is where a uterostomy is used. Ultrasound energy can be delivered by a probe as well. Stones are crushed and particles removed with graspers and irrigation. Electrohydraulic lithotripsy can be done intracorporally. And this is where a probe delivers a spark, which causes vaporization of water around the probe that results in cavitation. And if you remember back from our sterile processing chapter, cavitation is vibrations in the water that cause things to break apart. So that is what would happen to those stones then once that cavitation starts taking place. And then finally, we can use a holmium YAG laser, which we have seen in the past, if you remember back when we watched the cysto video. And they fed the laser up into the ureter, broke that stone apart, and then again we use a basket or grasper to bring out those pieces of stone. All right, moving on to just a little bit about a cystoscopy suite. Most facilities are going to have a dedicated surgical suite for cystoscopies. The cysto table differs a little bit from a regular OR bed. Fluid waste may be collected with an automatic fluid waste system or with a fluid pouch that's attached to the table and then drained with gravity, usually into a drain in the floor that will join up with the facility waste systems. Okay, and this here is an image of a cysto table. As you can see, it does vary a little bit differently. It's got its own built-in controls for our fluoroscopy. Table controls are here. It usually comes in with its own built-in stirrup system. The end of the table extends out further to allow for C-arm to get in and out. And this one here is actually hooked up to a gravity drainage system. So this here is that fluid pouch. This ring is attached to the table. The fluid will drain into the pouch. There is a mesh covering here to capture any kind of solid particles that may come out. And the fluid's going to drain through this tube and into a drain in the floor. This pouch is disposable. It is single use. So when the procedure is over, we simply remove that pouch and discard it and place a new one on the table before the next patient will come in. Excuse me. I'm going to ask you guys to refer to your textbook regarding the personnel in the cystoscopy suites. Your book refers to a dedicated cysto team. I will tell you, in my experience, I've been in many facilities and I have yet to see one with a dedicated cystoscopy team. So we're kind of across the board on those. So I will have you refer to your book for those personnel information. Talking about some fluids here. As we know in other specialties as well, if we are using an ESU, an electrosurgical instruments, the fluid used for distension of the bladder needs to be non-electrolytic. We are talking about sterile water here. That is what we want to make sure we are using if using an ESU. Okay, continuous irrigation for these procedures is provided in 1 and 3 liter airtight bags and a closed tubing system. Okay, fluids are generally kept in a fluid warmer, either in or very near that cysto suite. And then we're just going to verify with the surgeon on what type and what temperature of fluid is needed. They may not always want warm fluid, and that usually will be on the preference card, but we do want to make sure we're always verifying with the surgeon what type and temperature is needed. Okay, moving on to a bit about positioning. All right, positioning is going to be lithotomy if we're doing cystoscopies and ureteroscopies. Supine for any open position or open procedures of the bladder and prostate. Lateral for any kidney and ureter procedures that we're going to do open. And for nephroscopy, it's a bit of a different one. Those are going to be done in the prone position. Okay, like I said, we're going to touch here just briefly on some instruments and devices that are used. But again, you're going to need to do some self-study on these instruments. We do not have very many cysto instruments, if any, on hand in the lab. So we are going to rely pretty heavily on our books for these. Those instrument cahoots that you have made yourself will come in handy. I highly suggest that you refer to those quite often. But we'll go through a bit here. Okay, the first thing we're going to talk about is the measurement system. The diameter of devices or instruments for GU is measured in the French size rather than the metric system, just to make things a little more confusing. So the French gauge is equal to 1 millimeter. So for example, a 5 French catheter is equal to 1.67 millimeters. And 8 French is equal to 2.7 millimeters. It is very rare that you're going to have to do any kind of conversions. Usually our doctors know exactly what they need. It will be listed on the preference card as well. And they're pretty consistent from case to case. So when your doctor is asking for something, he will ask for it by French. And that is how the packaging is labeled as well. But just for reference, here is a little bit of a diagram of what those catheter scales are going to look like. So here we can see, here is the French conversion, millimeters and inches. So a 17 French is here, 16, 15, all the way down to a 3 French. And then here as well, 18, 19, 20, 22, 24, 26, 28, and so on. And here are millimeters and inches. But again, guys, they are going to always ask for it by French, and it is labeled that way. This is just for kind of a visual comparison and getting an idea of what those look like. All right, open procedures and instrumentation are going to use general and specialty instruments. If we're working on the ureters, we're going to want Babcocks, right angles, and tonsil clamps. Vessel loops are commonly used for retraction of the ureters. If we're working on the kidneys, we're going to be looking for pedicle clamps, vascular clamps, fine-tipped needle holders, and vascular forceps. The prostate procedures, honestly, are mostly MIS and robotic now. And then for the external genitalia, we're going to want to use very fine, very small instruments, normally from a plastic surgery set. Okay, this here is an image of a rigid cystourethrourethroscope. Excuse me. Let's see here. So if we look at it here, we have our telescope, which is right here. You can't see the end of the scope because it is fed through this little piece right here, which is called our bridge, and we will go through that in just a minute. It does have working channels to slide instrumentation down. And then this is our cystoscopy sheath, which our telescope is fed through as well. These are inflow and outflow ports for our water, and we'll go through this in just a few slides here. All right, so an obturator was not in that previous picture. This is a metal rod with a blunt, rounded tip. This is going to prevent the end of the sheath from abrading the mucosal linings of the urethra as it is inserted. So that sheath is going to go in with the obturator in place. After those two are in place, the obturator is then removed and it's replaced with the telescope. Okay, that little piece that we saw was the bridge that connects the sheath to the telescope. There are several types of bridges. They usually have 1 or 2 working channels for wires, stents, catheters, or any instruments that we're going to use. And then the sheath, which is where our telescope is going to go through. If we're doing something diagnostic, we're usually going to start with a 15 or a 17 French. And then if we have to do any kind of work, the therapeutic sheaths go from a 15 all the way up to a 28 French, depending on what we're doing and the size of the patient and surgeon preference. So again, this is just another image. Here up top is our sheath with our inflow and outflow ports. And you can see where we want that obturator in there when inserting it, because these are very fine metal edges. We don't want to cause any injury. This here then is our obturator, and you can see how that is a very rounded and very blunt tip. So this will slide into this portion. Here are 2 different bridges with their working ports here. Our telescope center down here, they're going to slide through the bridge here. Once this obturator is removed, this entire piece then is going to slide through here and connect. All right, moving on to talk about some urethral catheters. There is a table on page 606 that is catheters, stents, and their tips. I would ask that you refer to that to get a good explanation and some diagrams. Okay, catheters can be retention or indwelling catheters. They're designed to stay in the bladder for a time period. The most common of these is the Foley. Okay, Foleys with larger balloons, those are going to act as a tamponade. Okay, the tamponade just means that it applies pressure to that tissue to stop bleeding. That is a tamponade. Okay, we also have intermittent catheters. Those are referred to mainly our red rubber and our Robinson. These are catheters that are used to drain the bladder one time. They have no balloon. Okay, you will often also hear them referred to as an in and out. Okay, indwelling catheters are going to be used for drainage, bladder irrigation, hemostasis, and blood clot evacuation. Okay. So please do refer to that table so that you can get a good description of what each of these tips are. Okay. All right. Over here, this is an image of a ureteroscope used for ureteroscopy. Okay, it's used to perform endoscopic procedures of the ureter. The flexible tip allows entrance into the renal pelvis and those calyces. It does have working channels, much like the cystoscope, which we can see here, where we can feed instruments through if need be. There is a semi-rigid design as well that's designed to accept accessory instruments as well. And there is a box 25.1 that does go over ureteroscopy instrumentation. So you may want to look at that as well. Okay, the ureteroscope is usually inserted with the help of a guide wire. So we will place that guide wire up into the ureter and then follow it through with the ureteroscope behind it. So that guide wire then would come out of this working port, and we can pull it through and our ureteroscope will be in place. Okay, the ureter may be dilated with balloon dilators once situated in the renal pelvis. Instruments can be introduced via the working channels. Okay, we might use cup forceps for biopsy, the YAG laser tip for tumors and stones, baskets for removal, and so on and so forth for that. So that is what that working channel would be for. Okay, and then as I said before, the percutaneous nephroscopy, that's when that patient would be in prone position. That camera looks a little bit different. It's got a 45 or 90 degree offset eyepiece, and it's operated using standard endoscopy equipment. So our camera, our light source, a monitor for visualization. And it's usually, as I said, performed with that patient in the prone position. All right, ureteral stents. This is a type of catheter that's used in patients with an active kidney infection or with a diseased bladder. They may be used during or after a urinary tract surgical procedure to provide a mold around which healing can occur, to divert the urinary flow away from the areas of leakage, to manipulate kidney stones or prevent stone migration. They're also used to identify the ureter during difficult procedures. And this is what one looks like over here. They are going to come in different stents and styles as well. Your surgeon will ask for them. But as you can see, they're going to get fed up usually over a guide wire. Again, we'll follow it into the ureter. This black right here is what's called a pusher. So we will then feed that over the guide wire and push that stent up into the ureter as far as we need to get it. We'll then pull the pusher out, pull the guide wire out, and finally pull these strings, and that will leave the stent there in place behind then. All right, urethral dilators are used to increase the diameter of the ureter. There is a balloon style, which has an elongated balloon just below the tip that is inflated once it's in place. There are filiforms that are used with a follower and have a slender proximal end. These are inserted into the bladder, and then followers are attached sequentially to dilate that urethra. And then we have an olive tip, which has a slightly enlarged bulb at the distal tip. All right, moving on to some surgical approaches. We have transurethral, which we're using for cystoscopy, ureteroscopy. One thing to keep in mind is that these are considered clean contaminated cases. Though the instruments we are using are sterile, the area itself is not. It is clean contaminated. Okay, then we will use open surgery and again, MIS and robotic. Okay, so this is where 25 is going to end. Like I said, then we will spend one day on Chapter 25's procedures in class, and the next day then, time allowing, we'll either start them on that day or we'll do them the next day. And we will move on now into Chapter 26, which is going to cover ophthalmic surgery. Again, I realize these do not necessarily go hand in hand. But again, in the essence of time, these were the shortest two chapters to put together. Once again, just as with the GU instrumentation, use your Kahoots. We will try, if time allows, to go through instruments in class, but that is where these instrument Kahoots that you are creating are going to come into play. All right, so make sure you are referencing those. All right, so the goal of ophthalmic surgery is to restore vision. Okay, it is a very delicate and very precise specialty. Most procedures are going to be performed under MAC, or monitored anesthesia care. And that's because the patient is required to stay very still during these procedures. All right, so we're going to start out with some anatomy, as we usually do. We're going to start with the orbital cavity. The globe is contained within the orbital cavity, and there are 7 bones that come together to form the orbit. Those are the frontal, lacrimal, sphenoid, ethmoid, maxillary, zygomatic, and palatine. Okay, the palatines are paired, and those are what are going to form the orbital floor. Most of the orbit is formed from thin bones, However, the rim is very thick and protective. Okay, and then the optic nerve is going to enter the cavity via the optic foramen. Okay, so we can see here is our ethmoid, lacrimal, our maxillary. Here's our zygomatic, the superior orbital fissures. Our frontal bones are here in our sphenoid, and then here's our optic foramen right here where the optic nerve is going to enter the orbital cavity. All right, the eyelids are fibrous connective tissue that's covered with skin. They protect from injury and light. You will hear the word palpable. That refers to the eyelids, and the palpable fissure refers to the space between the upper and lower lids. The canthus refers to each juncture of the eyelid. Okay, and eyelashes are going to protect from airborne particles. Right, moving on to the globe. It does have separate cavities. The posterior lies at the back of the eyeball and contains vitreous humor. Remember, that is the very thick and gel-like humor that allows the globe to keep its shape. And then we have the anterior cavity that is divided into two spaces, the anterior and posterior chamber, and those contain aqueous humor. Okay, and they are enclosed by different tissue layers, as we can see here. Again, this is an image from your book. I know there's a lot of information on it, so you can refer to your textbook for this image. Right, moving on to the muscles of the eye. Vision is binocular. Before we get started on muscles, I want you to know that the vision is binocular, meaning that each eye has its own visual field. And those two are brought together as one image in the brain. The visible area is going to consist of a central and peripheral vision. And the visual field is that area we see when our eyes are focused on a single point. Okay, so that being said, then there are 6 ocular muscles that attach sclera to the orbit and allow movement. We have 4 rectus muscles, superior, inferior, lateral, and medial. And then we have 2 oblique muscles, superior and inferior. And there are several images from different viewpoints in your textbook. I would suggest that you reference those. Okay, but here we can see our superior obliques, our medial rectus, the superior rectus here, and our lateral rectus here. Okay, and that's what's going to, again, allow movement of the eye. Those are attached to the sclera. Right, moving on to the conjunctiva and the cornea. The conjunctiva is a thin, transparent mucous membrane that lines each eyelid and covers the sclera. All right, it's divided into palpable and bulbar regions. The conjunctiva covers the entire globe to the scleral corneal junction called the limbus. And the bulbar conjunctiva appears white because the sclera then is directly beneath it. Okay. The cornea is composed of 3 tissue layers, epithelium, stroma, and endothelium. Okay, it's a clear tissue layer overlaying the front of the eyeball. That should say front, not from. Light enters through the cornea, and it does not contain any blood vessels. Okay, during cataract surgery, the initial incision is going to be made through that limbus of the conjunctiva. And then again, there's very little bleeding because we're going to go through the cornea and there are no vessels. All right, the sclera then is the thick, white, fibrous tissue. It encloses 3/4 of the eyeball. So quite a bit of area is our sclera. The external layer communicates with the optic nerve sheath, and it is contiguous, as we said, with the cornea. All right, the choroid is a vascular pigmented layer beneath the sclera. It prevents reflection of light within the eyeball. Okay, and the ciliary body is an extension of the choroid. Okay, it's located at the periphery of the anterior choroid. It has smooth muscle that's contiguous with the suspensory ligaments that are attached. Okay. Right, the iris is a pigmented membrane. That is the colored part of our eye. It's composed mainly of muscle tissue that surrounds the pupil, and it then causes the pupil to open and close and prevent and admit light into the inner eye. Okay, this is what's going to control those pupil dilations. Excuse me. All right, the retina is the innermost layer of the posterior globe. Okay, it receives and transmits images to the brain via the optic nerve. And the fovea centralis is the center of the macula, or the area of acute vision near that optic nerve. Okay, the lens lies directly behind the iris. It is biconcave. It's a clear structure, and it's encompassed by a transparent capsule. It's held in place by suspensory ligaments called zonules, and it focuses images that are projected onto the retina. Okay. The lens is naturally flexible. It bends light rays and focuses them on the iris, as we said, and it's creating an image to be sent to the brain, but it is naturally flexible. Just a little bit here about our anterior and posterior chambers. The anterior chamber lies in front of the iris, and it's filled with aqueous humor. The posterior chamber is going to be directly posterior to the iris, but anterior to the lens. So it's going to be between the iris and lens. All right. The pupil is the only passageway between these two chambers. Okay, the pupil allows aqueous humor to pass between the two chambers through a space between the lens and iris. And then just as a review, then again, vitreous humor is going to be the clear gel that fills the space between the lens and the retina of the eye. It's in contact with the retina, and it helps keep it in place by pressing against the choroid. It does not adhere to the retina except at the optic nerve disc. That is just a bit of a review. What I want you to take away here is that these two chambers are filled with aqueous humor, and the pupil is the passageway between the two. Okay, we have the lacrimal apparatus, or our tear ducts. Okay, this is the apparatus that's going to produce our tears. It includes a few different things: lacrimal glands, the carbuncle, tear ducts, lacrimal sac, and the nasal lacrimal duct. The opening of each duct is referred to as the lacrimal punctum. Okay. So we can see here is our carbuncle, which is in the inner corner of our eye. Here are our lacrimal canals, our lacrimal sac. Okay, here is a puncta, just the opening of the ducts. All right, a lacrimal gland up here, and our nasal lacrimal duct. And again, this image is from your book, so you will be able to review it. All right, and last but not least, when we're talking about structure and function of our eye, is refraction. This is the bending of light rays through a transparent medium. Occurs as light enters the front of the eye and passes through the lens. The rays then converge at a focal point. The image produced is brought into focus by accommodation, and this is what enables us to view objects at various distances and keep them in focus. All right, moving on to some diagnostic testing. Excuse me, grab a drink here. All right, refraction. This is a test for visual acuity. It's performed with a phoropter, and a slit lamp is used to examine the anterior chamber of the eye. Okay, this goes into details, the lid margins, the conjunctiva, tear film, cornea, and the iris. Those can all be studied with this test. The pupil can be dilated and the lens and anterior vitreous can be examined. Fluorescein, you may want to review that from pharmacology, is used to stain the cornea and highlight irregularities of the epithelial surface. And then we'll use a tonometer to measure that IOP. If you remember, IOP stands for intraocular pressure. A direct examination is performed with an ophthalmoscope and allows examination of the fundus and other internal eye structures. Fluorescein angiography is where we are going to inject fluorescein dye intravenously. When that dye reaches the retina and choroid, the vessels and epithelium are clearly delineated, and those images can then be recorded. Okay, then we have ophthalmic ultrasonography. This is going to measure the density of the eye tissues, and it detects abnormalities. Okay, there are two types of ultrasound that can be used. Those are A and B scans. The B scans are going to produce an image of a target tissue that's going to show up as a series of spots. The brightness of those spots correspond to the tissue density. So as the tissue density increases, the images of those spots are going to appear darker. Okay, the A scan, however, is going to depict tissue density as an amplitude on two axes. So the output is going to be represented in waveform that kind of resembles an echocardiogram or an ECG. High density tissue is going to produce an amplified wave. And then, of course, as with any other specialty, we do have MRI and CT imaging that we can use as well. Okay, we'll move on to a little bit of case planning here. First up are the psychological considerations. Most of these patients are older adults, so they require a little bit more individualized care. That's going to take into consideration the environment, the room temperature, the choice of anesthetic, special written post-op instructions. All of these things are going to come into play. We want to make sure that we are creating a very relaxing environment. Blindness is a possible complication of these surgeries, and these people are aware of that. So they're coming in very nervous and very scared. That is why these procedures also are done under conscious sedation quite a bit. It is imperative that these patients stay very still and they override that normal reflex to pull away when they see something coming at their eye. So that oftentimes is why we will do that mat care or that light sedation for them. All right. Obviously we don't want them startled or frightened because we don't want to cause any injuries. All right, verifying the surgical site. This is rather important. The surgical team needs to be vigilant about the timeout for these procedures. Those surgical marks around the eye may be covered, or oftentimes they may be erased with the prep. So we need to make sure that we are, as a team, being very vigilant about those and verifying the correct surgery, the correct site, and the correct implant. The Joint Commission recommends that the surgeon mark the skin as near the operative site as possible, but that doesn't always work out. So we also will check with the patient for the correct procedure, the correct site, and the correct side. Before they're put under any kind of sedation, we'll ask them to verify as well. Okay, and when we're referring to implants, the AAO has a protocol to prevent wrong implants being used. If we implant a wrong lens, that can be very detrimental to these patients and cause a very, very serious complication. So before surgery, the surgeon's going to select that intraocular lens based on the patient's records, which are available right there in the OR. Excuse me. The circulator then, before opening that lens to the field, is going to show the surgeon the box and verbally verify the model number and the lens power. And then once that is done with the surgeon, they are going to repeat those steps with the surgical tech as well. And once it's open to the field, then the ST is going to verbally state the model number and lens power when passing it to the surgeon once again. So we are looking at about a total of 4 verifications of that implant before it makes it to the field. All right, patient positioning. These patients are usually going to be supine with the head stabilized in a gel pad that you will hear referred to as a donut. It does resemble a donut. A lot of facilities will use the stretcher or OR table combo as when we're shifting the patients. We need to make sure that we are being very gentle with them. Shifting that patient post-op can result in an increase in that IOP, and we do not want that to happen. So if your facility is not using a specialized eye table that patient is putting themselves on to begin with, if we are moving them from a stretcher to an OR table, we need to make sure that we are being very, very gentle and very delicate with those patients. Okay, and then this safe, comfortable, and pillow under the knees. An uncomfortable patient is going to become restless during that procedure. And as we've said a few times now, it is imperative that these patients stay very still. So anything that we can do to make them feel safe and comfortable, we are going to do. Remember, again, too, a lot of these patients, the majority are going to be of the older population. So a pillow, something as simple as a pillow under those knees, is going to relieve pressure on their lower back when they're laying there. And that will also help for that comfort level and that stillness level. All right, when we're talking about prepping and draping, we are going to use a standard approved prep across the board for eye procedures, and that is povidone iodine. We're going to need to gather some supplies when we're prepping, small basins for the solution, surgical towels, lint-free gauze sponges, cotton balls, cellulose eye sponges, and BSS. If you remember, BSS is our basic salt solution. All right. The patient's hairline is going to be secured with an adhesive towel. The ear may be plugged with a cotton ball, and towels might be placed around the patient's face and under their head just to prevent and catch any runoff. Prep is performed starting at the eyelid and extending outward to the brows, the margins, inner and outer canthus, the brows, the face, and the chin. And one thing to remember is that canthus is considered a contaminated area, so any sponges that come in contact with that will need to be discarded. All right, anesthesia for these patients. Most procedures are done with a regional block and then monitored sedation. Pediatric patients are going to receive general anesthesia. It is veritably impossible to keep those little guys still during an eye procedure, so they will go to sleep. Okay, we have the retrobulbar block is what we're usually going to use. This is when our agents are injected near the optic nerve. You may recall that from pharm. All right, they are often sedated right before retrobulbar block just because it is a pretty uncomfortable procedure. Okay, dedicated setup is prepared for local anesthesia for these patients, and that's going to include the anesthetic, syringes, infiltration needles, transfer needles, and sponges. The most commonly used injectable locals for eye procedures are going to be Novocaine, 1 to 4%, and xylocaine, 1 to 2%. And either of those may be, either of those might be combined with epi for vasoconstriction. So again, labeling is going to be absolutely imperative, as it is with any specialty. We want to make sure that these medications are clearly labeled as soon as they are received to the field. Topical anesthetics in drop form might be instilled into the cornea, and then it is applied over the cornea before injection as well. Right, some medications might be used. We're instilling them usually before, during, and after surgery. As I said just a second ago, all drugs need to be labeled as soon as they're received. Every drug must be identified when passed and received by the surgeon. Okay, pre-op drugs are administered by the surgeon or the circulator. And all drugs, as if any specialty, are, as soon as they're administered, they are going to be recorded in that patient's chart and in their intra-op report. Okay, we'll touch on some instruments just a little bit here, but again, like I said, you need to refer to your Cahoots and your instrument book as well. Just because there is so much information that is included in these chapters, you will have to do some self-study on that. All right, the surgical technologist should examine each instrument for damage before and after use with eye surgery. Again, these instruments are very delicate and very expensive, so they require a little bit of extra attention and care. The majority of the surgery is going to take place in the dark, so it's important for the ST to keep a neat table and know exactly where each instrument is located. Once we use an instrument and we're done using it, it needs to go back to its original position. Remember, a lot of times we'll be working under a microscope and you won't be able to look away. So you do need to have a good grasp on where your instrumentation is located on your Mayo and back table. Right, some equipment and supplies that might be used. We use two types of ESU during ophthalmic procedures. There is a single-use battery-powered cautery and the bipolar unit. Okay, the handheld unit, the battery-powered, has a small filament tip that becomes hot when activated. One thing to know about this is that it is a true cautery instrument. It has no cutting capability. Okay, and then if we do need cutting capabilities, that's when we'll use our bipolar. Okay, that's when we're going to use it for fine cutting and coagulation. And this instrument here on the bottom, this is a battery-powered cautery. So that's what it's going to look like. Okay, eye sponges are going to be made of lint-free cellulose. They are usually attached to a plastic applicator stick. They should be separated from any supplies that discharge lint. And one thing to remember is that the sponge is never used on the cornea. Okay, we are never going to use it on the cornea. It absorbs fluid by wicking, which means that we're just going to hold the tip of the sponge to the fluid and it will absorb. We are never going to touch it to the tissue. And this here is what one of those cellulose sponges will look like. So this tip would go just directly into the fluid, not touching the tissues, and it will wick up that fluid then. And you'll usually use several of those in the course of a procedure. Okay, sutures for eye surgery come in sizes 4/0 to 12/0. So they are very, very fine, very delicate sutures. They need to be handled very delicately. Because they are so fine and thin, they will snap and break easily. Oftentimes they're going to be double-armed, meaning there will be a needle on each end. And that is because we're going to be doing a lot of circumferential incisions that need to be closed. Okay, those needles are going to be just as fine as the sutures, some as small as 4 millimeters at their widest points, so very fine needles. And again, these should never come in contact with our cloth towels. We do not want to risk any kind of lint getting into those sutures. Right, and our ophthalmic dressings may include soft dressings over the eye with gauze and tape, lint-free of course, or a hard shield to protect that eye in orbit, or a combination of both. Moving on to just a little bit about microsurgery. The surgeon's field of vision is magnified. The scope, or the area of vision, is very limited. The surgeon is unable to look away from the field when working under the scope, so the scrub needs to prepare ahead for each step of the procedure. A lot of times you may be working on the scope with them. That's where we need to know exactly where our instrumentation is at. And we need to make sure that we're preventing any movement of the microscope. It may sound silly, but limit your caffeine intake before scrubbing for an ophthalmic procedure. to make sure that our hands are steady. The ST needs to pay, as I said, close attention to the case. You may be viewing that surgical site through the microscope, so you need to make sure that you are taking extra care not to move or bump the microscope during that procedure. We do not want to cause this patient an injury or cause the surgeon to lose any kind of concentration. So it is imperative that we have a steady hand, not to make you guys nervous, but it is important. Okay, another thing that I want you guys to pay attention to is box 26.1. That is on page 644. And that is going to have your microscope terminology, different bits and pieces of the microscope that you should be familiar with, as well as care and handling of the microscope. That is also included there. So please make sure you review that. All right. And finally, we're just going to cover a little bit of the role of the ST in ophthalmic surgery. As I said before, we're going to be checking our instrumentation for any damage. We want to make sure we are keeping our instrumentation clean, using only the lint-free materials. We're going to handle and load our sutures properly. A little bit of a finesse comes with handling these very small needles. When cutting sutures under the scope, it's a little bit different than cutting during an open procedure with those larger sutures. You're going to place the scissors within that field of vision under the scope. You're going to position the scissor tip at the suture, and then we're gently lowering it down for cutting. Okay, we're not just going to go in and cut the suture. There is a few steps that go to it. We want to keep our instruments, as I said, in a specific order on the Mayo. Experienced scrubs, as they get into eyes and have done it for several years. When I say experienced, I'm talking a few months to a year of training. These guys don't have to move their eyes from the scope to position an instrument in the surgeon's hand, which I find fascinating to watch. They never look away. They can take that instrument and put it in the surgeon's hands and never lift their eyes from the scope. And periodically as an ST as well, we're going to irrigate the eye with that BSS. Again, making sure to never touch the tissue when we are wicking that back up then with our sponges. All right, so that is what we are going to cover for chapter 26 here. Again, like I said, we'll go through some stuff in class together, but that is where we're going to end this lecture. Please, like I said, make sure that you are reviewing your Kahoots for instrumentation and your books. Make sure you look at those tables, review those diagrams, and we'll go through some procedures in class. Any questions, make sure you leave them here. And with that, I will see you guys in just a little bit.